So I'm Brenda Kelly. I'm a consultant obstetrician in Oxford, and I also hold the unenviable role of clinical lead for maternity safety. I'm also a friend of Stella's. We met in a basement kitchen in a party in East Oxford about 5 years ago, which is how we ended up having early conversations, which I think Stella led to today in many respects. So my friendship with Stella is both professional and personal. And what I have today in coming to this room is a sense of joy. This is a joyful occasion, bringing together such a diverse group of people interested in birth and birth care. I'm also filled with curiosity. I'm actually really excited about where this might lead to. One of the early questions I had, you probably don't remember this, Stella, at a seminar in St. Catherine's, where I listened to Stella speaking about controversies in philosophy of birth. And as a bench scientist and medic by background, I kept thinking, where is the translation into clinical practice? But what we have here today is a wonderful safe space, which I hope will just grow in terms of the network, where we can express these ideas, but also learn. And this concept of bridging that silo, the conversations that have been happening amongst philosophers of birth and in the medical humanities have gone on for so many years. But most of us who work on the front line are coming through universities where the concentration has been on acquisition of knowledge and practical skill, specifically around reproductive anatomy and function. And there's just this enormous wealth within the network, which, as I say, just fills me with joy and excitement. And I think it is something to really celebrate today. So what I'm going to present here in the next 10-15 minutes isn't a discourse on how we must do personalised care better. I was mulling over the title, so I put down challenges to personalised care. I actually changed the last minute, which is what can we do? Because it's not about what you or I, what can we do collaboratively. And what I'm going to do in this is take the sort of the challenges that we see daily, and Stella talked about how we tell our stories, how birthing people tell their stories. I want to take some of those stories. I want to take the perspective of a job in obstetrician, because that's what I am. I don't have a philosophical background. And I want to share with you my journey with Stella, okay, and how she has been one of the most wonderful friends, but also one of the most challenging friends that I have, but also how the conversations we've had over the years, which to me were conversations, but from Stella, these were philosophical analysis, and how that has led me to think very differently about every single interaction I have with a woman, pregnant woman, a birthing person. So I'm going to have to challenge myself to work out how to use the keyboard here. So just bear with me. Okay, Ruth, the button that you said to use isn't working.
Just click on the screen.
Click on the screen. No, the mouse. Okay, let me get the mouse over. I'll click on the screen. Yes. Okay. Right, so let's start with something very basic. Stella said it's about how people tell stories. And the first step in terms of that challenge to personalised care is, this isn't about another policy, protocol, guideline about personalised care. And we know, for anyone who works in the UK, personalised care is very much the zeitgeist term at the moment. My fear is it'll become a tick box exercise. So I think at the very heart of this is that women and birthing people are talking. And this isn't just in this sphere of maternity care. They're talking now in a way that they haven't talked before, and they're having platforms. They are trying to redress the imbalance that has existed in our societies. So the first challenge is how truly radical would it be to listen to these women? Now, as we consider personalised care, we can reflect on the things that we do well. And Sue's going to talk about the safety 2 perspective in maternity care. So there are many things that we do well, and we can reflect about what is it when we get a letter or a card from a patient, what is it that they're complimenting us about? But as we know, our media or reports that have come out in the last few years are filled with the narratives of women who don't experience good care. And these women aren't just talking, they're roaring out their distress. They're shouting out about the harm that they or their babies have experienced, largely unintentional, through the care in our system. And it would appear, and these quotes are taken from a wonderful report that Birthrights published in 2022, very much around systemic racism that exists in maternity care. So it would appear that the harm and the hurt that women are experiencing is greater the darker your skin and the less that you look like, sound like, or educated as the person giving you birth care. When we try to unpick some of these narratives, what we find is that women have felt dismissed, trivialized, coerced into, or excluded entirely from decisions about their bodies, their pregnancy, their babies, and their care. And what the narratives have in common is that description of the loss of agency, autonomy, dignity, and simply not feeling valued. And what we're being called out on in that sort of journey into achieving personalized care is a number of ways that we have disregarded, denied, diminished women's personhood. Because agency, autonomy, feeling valued, oh my goodness, it's gone on speed. Women's agency, oh, it's going to happen again. Okay, I'll just skip to this. I'm not going to battle with the computer. But women's agency, autonomy, having dignity, feeling valued, these are attributes of personhood. And I remember reading this from Baroness Hill's judgment in the Montgomery case. And, you know, this would fill you with joy. If you're a pregnant woman reading this, you'd say, well, actually, this is joyful. We're actually in a position now that we are being regarded as fully entitled citizens, fully autonomous beings. And when we think about that care of a woman, the birthing person's personhood, I think that tension between what Baroness Hill would like us to be doing and what actually happens, that tension is greatest in the labour room. And as an advocate of upholding personhood, and when I have these conversations with frontline colleagues, I often get this sort of narrative back about actually it's just so hard. We recognize that person didn't have a good experience, but it's actually really hard to work in this public resourced health service that, you know, and happy birthday NHS, but we work in a system which has got severe resource constraints. We're very busy, the workflow is hard, we don't have enough midwives to cover a shift, there aren't enough doctors or they're striking. You know, there's lots of reasons why it's difficult to uphold personhood. But I would say that those same organizational and structural issues exist across the NHS. But I don't hear the same narratives happening elsewhere. So what is it about maternity specifically that makes it so difficult to uphold personhood? And this has been one of those conversations that I started with Stella about 5 years ago. And it started around something very basic, which Stella alluded to in her introduction. We were having a conversation about birth care, and I was talking about how I'd want to rip up the consent form, because what is the point in having a consent form in a woman in labour? And Stella's look of absolute horror made me feel very uncomfortable because what it led to was an entirely different discussion about what was my view on consent? Why did I think that consent from a person who's experiencing fear, distress, who's contracting, might be any less valid? Or why might that woman so obviously not have capacity in that moment? Why would she be so obviously irrational in her behavior in labour that would merit a clinician who thinks herself a good person to think that that woman does not have validity or the capacity for consent? And so through these conversations, I have been faced with something very uncomfortable, that whilst I think I'm a decent clinician and a decent human being, actually in my practice, I've been harboring, is that the right word, an unconscious gender bias. Now that's a very difficult thing to sort of, I feel like I'm standing up at an AA meeting. It's a very difficult thing to talk about, But this is that benefit of bringing together a clinician and a philosopher. Actually, let's examine this in a safe space. Why is it that I have this thing in my head, in my practice, that I hadn't yet examined? And I think we should put it back a little bit, remembering that that birth room is an interface between the practitioner and the person giving birth. And into that room, each side of that interface brings into it internalized constructs, which are partly historical, partly embedded through the ages and through the way we've been educated. And so, Stella, thank you, because you've revealed to me something which I didn't realize I had. We could also analyze this in a different way, because we know, as the birthrights document talked about, the systemic racism and the unconscious bias we have around race, the unconscious bias that we have towards many different aspects of what it is to be human, whether that involves race, color, gender identity, education. But that sort of notion of the birthing woman as being somehow irrational, lacking capacity, where does that come from? And really, we have to stretch our minds back to sort of the birth of modern obstetrics, which gave sort of new strength and new energy to the ideas that linked inferior mental capacity with reproductive function, the possession of a uterus. And whilst I would like to think that in modern day medicine and obstetrics that no longer exists and that we're free of those prejudices, I have to say that the more that I reflect on when things don't go well and when I see these narratives, the more I'm convinced that those constructs, the notion that a possession of a uterus renders you uncontrolled, wild, incapable, are ever present in the way we practice obstetrics and midwifery. And I'm going to borrow from Stella here. This is directly from one of Stella's papers. And to summarize an entire philosophical analysis, put simply, a woman under the uterine influence does not reason well. And we can go one step further, because we can also then start to think about what it is, who it is we're caring for in labour. So quite often, if we think about Barnes Hill's, her desire is that those days are gone, but actually Barnes Hill, I'm sorry to say, those days are not gone, they're simply internalized. Because what we have is the movement, the sort of the ongoing practice, however much we want to deny it, in terms of personalized care. If we're going to get there, we have to first tackle the fact that over centuries, we have moved a pregnant person from being a fully entitled subject quite often into an object. And that objectification is partly through the language that we use. So let's just pause for a moment and think about the vernacular. Quite often we remove the word woman or birthing person or even their name from the sentence. So for anyone who works in delivery suite, this will resonate with you. The VBAC in room 6 needs an examination. The induction of labour needs to come down from the antenatal ward. The BMI woman in that room, in our vernacular, we are removing. And in that sort of objectification of the woman, it is easy then to assume that they are just simply the vessel. And again, I'm borrowing from Stella here, that they are somehow the vessel with a very precious cargo. And the vessel cannot be trusted to get that cargo safely into port. And so therefore we excuse the fact that we step on board, we take over control of that ship. Now, if we think about the vernacular, I know I've worked in deliveries, I've been doing obstetrics for 20 something years, I know that we use shorthand. I'm not dismissing the fact that sometimes in a hurry we might use that language. But if we think about what happens on an individual delivery suite, and then we think that that is happening across different delivery suites in your region, in your country, across your nation, across continents. And what we see here is how those old wheels of gender bias keep on turning. So I'm going to finish which is a simple reflection, that when we think about personalized care, the first step is that care of personhood. And that care of personhood extends not just to the person who looks, sounds, speaks like us. It extends across that intersection of unconscious bias. And part of the reason why I feel very joyful about today and about the launch, the birth of the network, does that make sense? Yeah, but the birth is that we can have these conversations and we can challenge the next stage of development within maternity care, particularly in the UK, around personalised care. We can reflect, but can we please also remember the power of the individual? So every single person has, when we work on the front line, we have care contacts, and every single care contact counts. And if in that individual care contact, we can be mindful that we all have those internalized constructs, and if we can reflect how those play out when things go well, because quite often we're being complimented on the fact that we have listened to the woman, we have seen the woman, and we have maintained her psychological safety, we have upheld her personhood. And when things don't go well, it's often that we've done the opposite. So then, let's take the opposite of the vernacular conversation. If you imagine that happening in your contact, every contact, in your delivery suite, across your country, across your nation, across the continent, across the world, then what we have is that sort of flap of the butterfly's wing that shifts the air, but if we're all doing it, it creates that hurricane across the ocean. And that, I think, will lead to the change that we all wish to see. Thank you.